Good evening, everyone. A very warm welcome to WGH India Dialogue Series. Thank you for joining us today. Um, we have been conducting this series for this week, starting the conversation from session 1 on community level perspectives, moving on to session 2 on state level perspectives, and we hope to connect the dots in session 3 today, hearing from our national level stakeholders on engagement of frontline workers in COVID response work. Before I hand over to Sumega, who's the moderator for today's session, I would like to quickly take you through the key points discussed or raised in session 1 and 2. Starting from our first session held on Monday, where we heard directly from the people working with these ASHA workers on the challenges that they are facing while working on the ground, how their public and private boundaries are getting blurred. The care work that they are doing is largely seen as coming under women's domain, and they're supposed to do the care work as volunteers and not necessarily seen as the service providers. So it was reiterated by the panelists for their contributions to be recognized as a critical component of the functioning of health systems. Second was that COVID has tremendously increased the responsibilities of already burdened ASHA workers, including a range of activities. And I don't need to mention that, all of us know. But the point here is that this has brought in an element of violence and stigma and discrimination, which needs to be seriously considered. So as they now face the brand not only at home but also from the community where they work. And lastly, for the need to have a robust feedback mechanism to take into consideration ASHA's concerns, experiences, and lived gendered realities from the field and feed them into the health system to make it more responsive to their needs. Building on what we heard in session 1, we brought in the state level stakeholders from the government, civil society, and the development partners to understand how they have been handling these concerns of frontline health workers at their state and regional levels. There were quite some encouraging initiatives shared, ranging from proactive engagement and support of block level and district level officials in assisting the frontline workers to the field whenever they faced discrimination of any kind, to building their capacities and following through their work to capture their learning and participation. And this came from the northeastern region. To conducting extensive surveillance activities using participatory learning and action approach, PLA approach in Jharkhand, that helped mobilize the community to support frontline workers and assist them in carrying out their activities, and how strategically designing communication messages can prove to be more acceptable, like why washing hands for 20 seconds is important, or that tricolor messaging for food. Along with these initiatives, a constant reliance on ASHA workers for all the additional work was reiterated for their easy accessibility and closeness to the community, making them a critical component of the health system, but were also provided with limited resources, capacity, and support to fulfill the numerous tasks allocated. Another critical point that was highlighted was that the increased emphasis on the role of frontline workers in the program implementation and so many other activities, but with limited or no clarity on their roles and that of the higher level service providers. So there was a need identified to clearly define the roles and responsibilities of each service provider to prevent any confusions or overlaps in the service delivery. And lastly, various states have been honoring the ASHA workers and the frontline workers with awards like Corona Warriors, Corona Fighters, giving them letters of appreciation, which is absolutely necessary and important, and more so to address the concerns of stigma and discrimination that these frontline workers are facing while visiting the community. But the question is that our attempt shouldn't end here. We need to equally pay attention to taking these concerns and lived realities into the decision-making spaces to make the health system more responsive. So this is a very quick and short summary of the previous 2 sessions of our dialogue series. And I request everyone to please go through the recordings and summary notes at your convenience. We have already shared that in the email. So with this quick summary, I warmly welcome you once again for joining in and hand over to Sumegha for beginning the session. Sumegha, over to you.
Thank you, Deepika, and thank you all for joining. Thank you to all attendees for participating as well, and we look forward to receiving your questions. In the panel today, we have Ms. Urvashi Prasad, who has extensive experience in health, nutrition, sanitation, gender, and public policy. Over the last 3.5 years, Urvashi has been working as a public policy specialist in the Office of Vice Chairman at the Niti Aayog. She is currently supporting the work of Government of India's Empowered Group 1 for managing the COVID-19 pandemic in the country. We've also been joined by Dr. Rajni Ved, who's the Executive Director at National Health Systems Resource Center. She provides technical supports. NHSRC provides technical supports to the Government of India's National Health Mission at center and state government levels. Her work focuses on linking community processes with health systems and supporting the implementation of comprehensive primary health care. She has over 30 years of experience as a practitioner researcher, and her special interest is implementing research and scaling it up to the large health systems level. We've also been joined by Dr. Hilde, who's the team leader for health systems at Country Office for World Health Organization in India. She's extensive experience in public health and health policy development in low and middle income countries, in the field of human resource for health, on retention of policies, HRH information systems, and planning of district health care teams. She's a member of WHO India Emergency Team for COVID Preparedness and Response. We've also been joined by Dr. Vani Sethi, who's been working with UNICEF India on advocating women's nutrition through Ministry of Health and Family Welfare and NRLM platforms for over a decade. She has over 18 years of experience in working from grassroots level to national level in varied capacities for advancing access to nutrition services for women in marginalized, tribal, urban, and rural communities, been working with USAID and Ministry for Women and Child Development. A common thread in her work is partnering with women collectives as equal stakeholders in decision making and implementing programs. She has several publications, books, and chapters to her credit. We also have with us Dr. Priya Nanda, who's the Senior Program Officer with Bill and Melinda Gates Foundation at India Country Office in the Measurement, Learning, and Evaluation team. Dr. Priya leads a portfolio of research on health system strengthening and family planning with a focus on gender, social norms, and equity. Prior to joining the foundation, she was the Director for Social and Economic Development Group for ICRW, the International Centers for Research on Women's Asia's regional office in India. Her expertise includes research, measurement, and evaluation of women's economic empowerment and access to health services, including reproductive and sexual health. Once again, a very warm welcome to all my panelists and the participants. Few housekeeping rules. All participants joining us in the dialogue will be able to see a chat box, and we look forward to receiving your questions in the question tab. We also have translators in our chat box. Please keep a check on your chat box if you're looking for translations from English to Hindi. Reach out to us in the chat box again if you want any kind of assistance. We'll be recording this session and the recordings will be shared publicly. You can adjust the size of your screen as per your liking, adjusting to see the views of the speakers or the presentations. We begin with today's session, and I'll start with Ms. Urvashi Prasad. Ms. Prasad, over the last 2 sessions, we've heard that the FLWs are central to the pandemic response. Yet they're distressed about being overburdened, underpaid, and excluded from official and community recognition of the contributions to the pandemic. Most part of this is because they feel that the policies are not responding to their needs. What opportunities do you see in the policy processes for including the realities and concerns of FLWs? Over to you, Ms. Prasad.
Yeah, I think I'll start off with just a couple of high-level areas from the policy perspective, where I think we can address a lot of the issues that have been raised, even through your platform over the last 2 days. I think one is, we've had this pandemic, unfortunately, but I think it really also provides us an opportunity to think about our public health and primary care system now very systematically and very strategically. I think some states have already done it, some states are already well ahead in that, but there are many others which are still lagging behind. So I think we need to think about how we organize our public health and primary care, and where the different cadres fit in to that structure. So I think rather than thinking of whether it's community health workers or any other cadres of health professionals as just individual cadres delivering their own set of services, we need to think of how we better organize them into teams, delivering public health primary care services with shared objectives, shared goals, and ultimately, improving outcomes in health and nutrition. I think a lot of times there's an emphasis on individual services, but where that fits into the big picture is sometimes not clear, even to the stakeholders themselves. So I think that's a big opportunity, and if we do that, from there will flow, our ability to address a lot of the challenges of workload, rationalization of how we monitor performance, how we compensate and incentivize commensurate to what we expect, our cadres of health workers to do. So I think that's one whole piece. And the second piece is on technology. I think because technology is a key enabler, and we've started building in technology, into a lot of our policies and programs in the health and nutrition space. But I think we need to be very cognizant of the human and behavioral aspects that go alongside the technology. So again, because I've spoken to a lot of health workers working at, say, health and wellness centers, for instance, and I'll speak a little bit more about those, who say that yes, we've got these tablets, we've got these technology tools, but we really need to understand better, what happens to the data we feed in here, how does that come back to us, so how does the feedback loop close? And what use, is eventually made of all that information and data. So I think those are some of the aspects that we need to think about more carefully from the policy side. And the center, at least in two programs that have been launched in the last few years, has tried to bring in some of these perspectives. So one is the health and wellness centers that I was talking about, which is one of the pillars of Ayushman Bharat, where the idea is very much to think of it as a team, which would be running these health and wellness centers. It would have a mid-level care provider. It would have different cadres of, frontline health workers. And then each would have sort of clear roles, responsibilities, monitoring, etc., would go along with that. So I think that's been one attempt to think about it more systematically. The other is in the Poshan Abhiyan, for instance, and we got this, based on a lot of feedback from states. We've tried to bring in elements like joint incentives, for Ashas, ANMs, Anganwadi workers, because sometimes we create this sort of artificial separation between health and nutrition. So we've tried to bridge some of that and create actually joint teams, joint incentives, and at least reflected that in the overall sort of framework of the Poshan Abhiyan. So I think, these are a couple of efforts that the center has tried to take. Now, of course, India, health is primarily still a state subject. So a lot of the contextualization implementation happens at the state and sub-state levels. But I think there is an opportunity for the center to provide this sort of template framework for how do we really organize our public health primary care system. And of course, the community health workers, the frontline health workers being a very integral part of that. But sort of fit them into the bigger picture.
Thank you, Ms. Prasad. That was very insightful. And thank you for bringing in the idea of systematically looking at FLWs and how they fit into the public health systems. Moving over to Dr. Ved. Dr. Ved, over the last 10 years, we've seen the evolution of ASHA program from merely being very instrumentalist in its approach to being exploring the empowering potential. What new opportunities do you see with the COVID coming in for adapting policy initiatives to be more responsive to the capacities and the layered realities of frontline health workers? Dr. Ved.
Okay, thank you, Sumegha, and thank you for having me on the panel. What I'd like to say about the two policy initiatives is that I think when policy initiatives are formulated, they need to be looking at the past as well as current and the future realities. The ASHA program particularly is replete with instances of policy evolution that have matched the progress of the program in the field. So every policy document that was released as part of the ASHA program had its origins in some finding in the field, where we then looked for evidence that it worked, looked at how much it worked across states, and then converted it into policy. So whether you look at the career progression pathways for the ASHA certification process, and in response, I think particularly, I think we need to be cognizant of the fact that all of the payments and the new incentives, the new tasks that were introduced for the ASHA actually came from some evidence in the field that the ASHAs themselves had evolved beyond what was imagined of them when the program was designed in 2005. I think that's one reality that we keep in mind. So increasing her competency, which I think took a lot of people aback, because the original vision of the ASHA, even though it was always articulated as being a link worker, a community mobilizer, as well as a community level care provider, in many people's minds, she was still only to be a link worker. Matching her, I mean, creating opportunities to increase her competencies was very much a policy decision that came from the fact that where the ASHAs worked in the field, we really had nothing else, particularly in many of the remote districts of the state, so of the states. I think the second point I'd like to say is this clubbing of all workers into frontline workers is a bit problematic. At one level, we talk about different roles and responsibilities for different workers, and then we put them all together in one box and say frontline workers. So I think we need to be very clear on our expectations of different workers, and maybe nomenclatures, and nomenclatures are very, very important. The ASHA is not equivalent to the Anganwadi is not equivalent to the ANM, and yet we put them all together. So I think that's an important consideration that we really need to look back. I've heard over and over again, also looked at your notes from the webinar, to say, clarify roles and responsibilities of the frontline workers. They are clarified. It's only that you have to define which frontline worker you're speaking about. So I think that's important. And I'm just going to say this one thing about ANMs, which I think the ANMs have been an ignored worker for a long time. If you look at frontline workers, ASHAs have got a fair share of the attention. There have been dedicated teams at the national and the state level to support the ASHA, and the policy evolution of the ASHA program that you see in the last 15 years has been as a result of this. But the ANMs, unfortunately, have been a neglected lot. And remember that they are the first outreach point of the health system in the community. The ASHA is designated a volunteer, but the ANM is the one that is responsible, or has been till the community health officers or the mid-level health providers came on the scene. So I think that she is a neglected worker, and we need to pay attention to the ANM as well. But that's for the future, and I won't repeat that. I think the third point I'd like to make is the COVID pandemic really highlighted to us how the role of the ASHA, we had her as a worker for reproductive, maternal, newborn child health, and she performed that role fairly well. We moved on to adding non-communicable diseases. And in some states, vector-borne diseases was an important part of the ASHA's role, but not across all states, much less in urban areas. And I think the pandemic has brought to the fore the fact that we must have policies now in place where we build the ASHA's competencies. Of course, we build her competencies, we build the support that's provided to her, whether in terms of knowledge, whether in terms of the kits that she needs, and whether in terms of the remuneration that she needs, to enable her to respond to public health needs, which we haven't done. Of course, she is part of the tuberculosis program, she is part of vector-borne diseases, but that is still rather uneven, and we need to strengthen that part of it. Coming to health and wellness centers, I think again, this was an important policy evolutionary measure that ensured that the ASHA became an integral part of the primary healthcare team by positioning the whole health and wellness center as a place where the primary healthcare team led by a mid-level health provider is in place, and by defining, and if you look at all the guidelines and the policy documents, they say very clearly that the ASHA is an integral part of the team, and we define the team as a mid-level provider, as two multi-purpose health workers, and as the 5 ASHAs of that area. So I think there has been a policy shift, and the policies have evolved to make sure that the ASHA becomes an integral part of the primary healthcare team. And as we all know, PHC is the foundation of any system, particularly as we work towards universal health coverage. And finally, I'd like to say that there have been umpteen attempts to ensure that the ASHA becomes a part of the health system, but retains community credibility. And that's really a very difficult bridge to navigate. How do you ensure that she stays rooted in the community, but it also becomes responsive to the health system? But I think across the country, we have examples of that. And she has built up enormous social capital. We have heard of tragedies happening within the COVID pandemic, and they've happened across. In the 15 years, there have been innumerable instances of atrocities against the ASHA, of poor payment. But over time, states and districts have evolved to address this. Not all equally. This is a huge country, and we have diversity even in the responses to the ASHA program. But I must say that policy change has happened. And the ASHA, because the ASHA is now seen as central to the health system, sometimes it's worrying, she gets overburdened with it. But my sense is that the program has evolved to meet the realities of the ASHA, but also to adjust her competencies to the needs of the program. I'll stop there. Thank you.
Thank you, Dr. Ved, for sharing those thoughts, for giving us a historical perspective and taking us through the evolution of the program. Moving towards the operational aspects, we see that data collection has been a key responsibility of frontline health workers if we talk about ASHAs and also Anganwadis and ANMs to a larger context. And the surveillance responsibilities have affected the FLWs the most during this pandemic. Dr. Hilde, how do you see that the surveillance activities can be adapted to accommodate the realities and capabilities of these workers? Dr. Hilde.
I'm unmuted now. Yes, I am now. Good, wonderful. Right, as you rightfully said, Soumya, frontline workers are playing a critical role in the ongoing surveillance activities as part of the control and response measures that we are seeing being rolled out in all the states in India to control COVID-19 pandemic. And the frontline workers, right from the beginning, have been involved and activities have been assigned to them. It ranges from house-to-house visits when returning nationals went home, identification of high-risk groups, contact tracing. It took another dimension when the migrant workers were returning home and the follow-up they have made millions of people who were moving out of the big cities, going back to their villages. So in all of these areas, they have been tasked with activities to collect data, to follow up on people. And the feedback that we are getting from the field is that so far they are doing very well in responding to all these different demands. And it is actually quite striking, and we should commend them for that they have quickly responded and adjusted to this new range of activities that they were given across the different states. But we are also hearing the difficulties that they are facing. And when I come to your question now, I do wish to point out or just summarize some of the realities that have been mentioned before. But if we want to improve data collection and make it easier for the ASHAs and the other frontline workers to do better on surveillance activity, we need to be mindful that with low education levels, with low literacy, it does make it harder to get involved in data collection and data analysis. The clarity of their role in surveillance activities, although we know that they have played they made a significant contribution in surveillance for malaria when there was outbreak, the whole immunization program. COVID is, again, a new reality for them, and questions around what they should do, and the institutional support mechanisms that they need for them to function well is missing compared to some of the other cadres in the health system. The high workload that they have and adding new expectations combined with the limited training that they will get for executing these tasks. And then the fourth aspect that comes up again and again is, of course, when you're involved in data collection, contact tracing, the gender dynamics, the stigmatization, and even the violence that we are observing. So that is the context wherein we expect the frontline workers to be more active on surveillance. How should we make it better for them? Well, again, 4 points. Number one, should never be ignored, is invest time in building their capacity. They need to be very clear on how to collect data. They must have a basic skill set on how you collect, collate, but also use data. The ease of data that we want them to collect, the set of or the list of information that we want to get from them, you need to make sure that it is standardized, that it is harmonized according different levels across different providers. And we should be very concerned that we need to keep the burden of data collection for frontline workers, but everybody who is involved in surveillance activities, we need to keep it to an absolute minimum. There is too much information collected that is never used. Then the third point, this is the use of data. Frontline workers are not only there to collect data and information, we should make it as part of their responsibilities and as part of our capacity building that data must also be useful for those who collect it. And that brings me to the importance of providing feedback. It should be an integral part of supervisory supervision, and we are looking here at supervisors and peers that when you work with data, data should be used locally and not only move upwards. Then use of technology. Well, we're in a digital world, there's so many opportunities. But when you want frontline workers to make use of the facilities that are available, we need to make the necessary investments. That means they must have the smartphones, user-friendly apps, use of a different type of program with animation, different approaches. But without the gadgets in hand, they will not benefit from what is now available. On the other hand, we're also aware that there is a mushrooming of apps. It's not unusual for frontline workers to have 5, 10, 15 different apps depending on the programs that demand information. Again, it's something we need to be very conscious about. Addressing barriers for using new technology comes back to building their capacity. And then as a last point that I would like to raise, and that applies to basically every aspect of the work they do, make sure that the frontline workers get the right incentives, job satisfaction, motivating them, also for data collection and data use is an integral part. Thank you, Samega.
Thank you, Dr. Hilde. Those were really valuable lessons, and we have a lot of learnings there in terms of use of information technologies and also use of data. In addition to data collection and surveillance work, frontline health workers have also been extensively involved in service provisioning. Dr. Sethi, would you like to share a few lessons from other sectors than health, like education and rural development, for policy adaptations for these workers from a frontline health workers perspective? Dr. Sethi.
Thank you, Sumedha. Greetings to everyone. If I can just have my slide projected, that would be helpful. So colleagues, at present, we have a good policy environment for adapting to COVID response. And as far as essential health and nutrition services are concerned, while the pandemic came in March, 10th of April, the first circular went out, and the ministry took lead, Ministry of Health, and very clearly laid out that this should be done using a systems approach. Unlike other countries, in India, as compared to the WHO systems approach, India has two additional pillars which the Indian government has been using since years: equity as well as community engagement and communication. And that remains our strength of India's health systems approach. Now, in the past 2.5 months, where we have been supporting active response of continuity of nutrition services in times of COVID across 17 Indian states where we work in with our partners, state governments, I would like to draw your attention to two workers who remain not discussed too much in the pandemic right now, but they are also at frontline. And hence I really resonate with what Dr. Ved said is, how do you define a frontline worker and how do you package all of them in one? The first set of workers that I would like to bring to the table here is school teachers. India under Ayushman Bharat has a huge school health program. Ministry of HRD's frontline is the teachers. And a lot of our work right now has been how can we support the teachers through the Diksha platform and other platforms that they're using to reach to the parents as well as the students on very simple online content. And colleagues, the problem that we are facing is that a lot of technology savvy material may be available, but most of our Indian context and where the deprived community lives is either low tech or no tech. And there, apart from simple phones and simple keypad use activities, nothing works, A. And hence provision of very simple ways to engage parents and children on ensuring A, that they receive the services at the doorstep, and B, correct information needs to be provided and harmonized. I'll give you one example. There are 100, if we look at India's adolescent program, the WIVS program, which has iron, nutrition, health education, as well as midday meal. While circulars have been sent that the midday meal should be provided at the doorstep and teachers should be providing that to the doorstep, how much of it are we seeing is being provided? One. B is that the children are locked in the homes. And they are being provided education material where we are trying to tweak the nutrition messaging within that, because there are lots of fears around food, what to eat, what not to eat, etc. And we are seeing that despite we have numbers of all the teachers in most of the states, WhatsApp messages are being provided to them. But the request that is coming from the teachers is, help us curate online content, because even the teachers weren't very used to it. So everyone is moving to an online new world. And that's colleagues for the teachers. The second group, which I would like to share with you on the challenges they are facing, are the community resource persons of the National Rural Livelihood. Just as the ASHAs, oftentimes the community resource persons who are actually the community and not frontline workers are often engaged also in several activities. A few things which we have tried to reach out to the CRPs that we are engaged with in Koraput, Bastar, Purnia district, is on the problems that they are facing and what are they seeing in the field, because these are areas that are the most deprived areas. And what they're mentioning is as follows, which we've tried to capture into the word cloud. Livelihoods are lost, jobs are lost, people are coming back. And because people are coming back and some of the family members are, there's a huge anxiety, stress, which is in the communities. People are very, very scared. despite government giving circulars and helping starting outreach services, people are not willing to take all those outreach services. So even their efforts to support Anganwadi, Asha, to mobilize the communities is getting affected because there's low support there. Their work itself, where they would work in, meet in small groups for group-based strategies, they have to do it through physical distancing and small groups, which is getting affected. The supply chain has been affected. So while those community resource persons that are providing take-home ration to the Anganwadi centers, today they have to do it at a doorstep. In addition to that, they are seeing discrimination, they're seeing violence. We have also seen pictures of women who've had their head shaved, and they were coming to me as pictures, and I was so horrified that why don't we have nutrition programs disjointed? Why do we have maternal mental health programs disjointed and health is separate? Why can't maternal malnutrition and psychosocial support programs be one programs? So while we have NIMHANS that has a helpline for them, there is a social welfare department which is providing another helpline on gender, but the woman there doesn't know who to go to for support. And these are broader issues. And the point I'm trying to say is that with schools closed, anxieties, discrimination, higher burden on the woman, no discussion about the male worker. There is an agriculture extension worker who's actually the 4th A. No discussion about him and how he can contribute. Even the community resource persons of the NRLM who were supposed to be engaged as community coping mechanisms and community livelihoods, loans, providing grain banks, reaching out to the most marginalized communities, are also engaged in service provision and active surveillance, and is affecting that work. The last 3 points which I would like to make is, first, when we talk of equity, and while it is always mentioned as a pillar, equity with dignity is important. And this comes straight from protection of the worker themselves. So for example, if there is a community resource person, a teacher, even workers, and those that are pregnant, ideally they should be on a maternity leave, but we are seeing them on a field. And that's the protection that we need. First, communications tailored to no-tech areas. In India, there are huge areas that are no-tech. Service cost and communication cost added to the work of the frontline people working at frontline. While we say we are giving we are giving so many crores of untied fund per district, no unit cost is provided. So I want to understand, is my worker being provided an additional communication cost? Because whoever we have spoken to, they've not. And finally, teachers brought into the discussion and also be incentivized, supported, and also shown as corona warriors who remain missed. Thank you very much.
Thank you, Dr. Sethi, and thanks for bringing in 2 more important workers, which we actually haven't really put in this discourse, the school teachers and also the community resource persons under NRLM. And another important point there about, male health workers that we have largely missed in these discussions at all. Moving forward, Dr. Nanda, we've observed in the discussions of the all female health workers and how the gendered realities of these workers are central to all these discourses. Would you like to share your thoughts on how the gender responsive approach and gender responsive approaches can be embedded in the current health systems approaches to effectively engage these female health workers? Over to you. Dr. Nanda, you're on mute. You're on mute. Now.
Muted you from here. You can speak now. Whoever is, just stop 1 second. Yeah, ma'am, now you can speak. You're on mute.
All right. I was saying that, I started by saying that I wanted to acknowledge back the discussions of panel 1 and 2, especially panel 1, which were really important to ground the gender issues that around frontline workers or community health workers that we are discussing today. The second thing I wanted to just acknowledge is that a lot of what I'm speaking from is also informed by my research partners, particularly OPM, and my other partners who've been working with us on knowledge mobilization and learning around frontline workers for the last 3 years. And some of it goes back to other examples that I'll bring from some of the work that I had been doing at ICRW several years ago. So in terms of it, Sumegha, you asked me to think about a gender responsive health system. The thing is that there's a lot written about theoretical gender responsive health systems. I think it's the practical operation or execution of what we say in theory is where the challenge lies. And I'd like to think about it in terms of a continuum of approaches, which has either on one end very systemic and structural, on the other end could be very instrumental and tactical. So we've seen some of the instrumental shifts even during COVID, the big recognition to frontline workers. And with all the caveats that Rajini said, they're not all homogeneous. Regions are not homogeneous. There are different types of workers. So I'm also in a broad brush talking about frontline workers, but I particularly am bringing examples of work that ASHAs are doing. So, overnight recognition, a lot of public acclaim, media attention, and that is tactical, that is instrumental. People now recognize an ASHA as a household name, where earlier she was completely invisible, not only within the health system, but also in the larger public discourse. So I think that's there's an opportunity here that we need to be leveraging to think about what could be a progressive gender responsive health system here on, acknowledging all the issues that have been talked about: stigma, harassment, lack of protection, unpaid labor, dispensing health frontline workers at will, in terms of, you just change their role overnight. They don't actually have a say. They don't have a say on their rosters. They don't have a say on their leaves. So there's a lot of problems that have been documented over the last few sessions. How do you really begin to address it? I think that at a structural or a system level, we really have to think about policies first. What are the policies for recruitment, retention, promotion, policies for protection against harassment, financial protection? And some of these have to now be gender responsive in this context, which is a different context than 2005 or even maybe 5 years later. Today, we are in a very different context. And so we need to revisit those policies. And any language that we create in those policies should be executable. And we have examples now. What is the kind of financial protection do they need? What is the kind of protection do they need? Protection within the health system from sexual harassment, protection against stigma, which is what they're facing in communities. And of course, physical protection that has come up in a very, very tangible way with COVID-19. So I would say that it's very important to revisit some of that. The second thing I'd like to say is in terms of people talked about male health cadres. They're largely invisible in the health system. We haven't optimally used them. How do we actually bring restore a balance in terms of actually rationalizing workloads, rationalizing roles, equalizing wages? If we do bring men back as in a big way as community health workers, it should be in a way to restore balance and equity and wage parity, as well as roles and responsibilities. I think we need to be thinking much more systematically about this, not to displace the status of women as health workers, but to really bring shared responsibility. And that is the same thing, it's the same kind of discrimination that women face in their homes and communities get replicated in the health system. The other thing is that we did see, Rajni mentioned the role of ASHA in the Health and Wellness Center, but otherwise in COVID-19, we do see a very integral role of ASHA as a connector within the health system to the community. But in reality, in their day-to-day lives, that is not the case. And I think the big piece that is missing, and here they talked about it in terms of data, but I would like to position that as a really important procedural changes in terms of improving supportive supervision for frontline workers. I think that aspect is really missing. And so that as a result, they're not part of a stream of accountability within the health system. The accountability only shifts down to the level of the ASHA or Anganwadis, but it's not distributed equally up through the health system, where she's an integral part of the health system. And I think that really needs to be considered how to do that. A lot of the solutions around ASHAs or Anganwadi workers actually have to be around changing leadership and management practices upstream and improving the competencies of leaders and managers so that we can actually distribute the responsibilities, the undue pressures that get situated downstream, and the accountability should be equally, and it should be like bi-directional. So I do think that's really important. And I think for this, my time must be coming to a stop. How many minutes do I have? Over?
Yes.
So I just want to say one more point, then I'll go back to my solution later, which is around, this was an example. This is a case or a long 10 years of work actually with Gap Inc. And ICRW, where we work with frontline workers in the garment industry. And so what I'm bringing is the need for really improving what OPM calls transferable skills. Skills that are not only technical, but they build communication, time management, decision-making skills of a frontline worker. And I think that has been experimented. I know Rajni can talk to that, but I think we need to really think through good models, profound, robust models of doing that, because otherwise a frontline worker, she enters as a low-skilled, low-capacity worker, and she stays in the system as that. So any opportunities that are theoretical for her vertical or career advancement are for naught, because there isn't the kind of competencies that we are building for her to really advance or grow. And those competencies are not just one-off training which is fit for purpose for that technical issue, but they're training that really builds her overall skills. So I think with that, I'll stop for now, and then you'll give us another opportunity later.
Thank you, Dr. Nanda. Thanks a lot for sharing those thoughts and laying out the wide landscape of issues that we should be looking at. And that's really helped us transition to the next phase of this dialogue. Reflections from this panel and also from the earlier ones echoes that there is a wide acknowledgement of the issues. There's a good understanding of its causes. And there's a great amount of willingness to support frontline health workers. As a next step forward, what actionable measures would you like to suggest for 3 key areas that we've identified? And I would want you all to share your thoughts on this. Ensuring gender responsiveness in policy making. Can we please have this slide? Ensuring better recognition from community and health systems, and enhancing capacities of frontline health workers. We'll do a quick round of suggestions and concrete action points from all the panelists. And you can also choose to speak beyond these if you think there are more relevant issues to address. We'll start with Dr. Ved.
Thanks, Omega. I noticed that you've given me the topic. Am I to speak on one or on all 3?
You can speak as much as you like on all, but so I will be just looking at actionable things.
Don't give me as much as you like. That's not right. So no, I will speak actually to the gender responsive policies. And Priya has spoken a lot about it. I think while yes, our policies, will fall along the spectrum from gender blind to gender transformative. In all honesty, I think they lie somewhere towards more gender transformative than gender blind. Certainly for the frontline workers, this has been true. But then what I think is a problem is that the policy is not translated through an orientation sensitization down to mid-level providers and the street-level bureaucrats. And I think that's where the problem is. So I wouldn't so much focus on gender-responsive policies as I would on policies perhaps to orient and sensitize people, both service providers and program managers, on what gender really means and how it needs to be transacted for the frontline workers. I think that's an important point. And because we know this through experience, we've sort of managed orders here at the national level, responding to incidents against the ASHA at the field level. But then they often remain as orders unless there's a constant follow-up and advocacy. And in this structure, in the society that we live in, which is, we know that it's often gender blind. We need a lot more to be done at the lower levels. And so policy, while important, programmatic action and advocacy is very, very important. I think the capacity building, I couldn't agree more. I think building capacity is transformative and is very, very empowering. Non-literate workers who can manage pictorial modules are a delight to watch. So I think our investments in capacity building have to be much more nuanced to the situation. I mean, the ASHAs were selected in 2005. Now we are in 2020. We're giving them new roles. We're expecting them to be adept at smartphones. But how much capacity are we building? I'm a firm believer that capacity can be built so an ASHA can actually become a gynecologist someday if we plan that future carefully. And so I think the investment in capacity building, and there has to be buy-in. There has to be buy-in again from every level. At the national level, of course, there is a lot of buy-in. At the state level, I would say there is a lot. But you need society to accept the ASHA as a key frontline worker. And I know from experience that in urban areas, we have not been able to see the kind of openness to the ASHA as we have been seeing in rural areas. And that's really an area for us to consider and say, what different capacities do ASHAs in urban areas need than rural areas? What different capacities do ASHAs in states where diseases have progressed more towards chronic and more complex condition need than in the states which continue to have a high burden of RCH? So I think even capacity building can't be just one lump sum training module, a cascade of trainers training the same things. It has to be, because we are now 15 years into the program. And we really have to evolve our training methods and to meet the needs of the future. Thank you.
Thank you, Dr. Ved, for bringing in two important points of translating the gender responsive policies and also looking at tailored policies as per the different needs. Dr. Sethi, would you like to share some reflections in terms of actionable points?
I think from my point, I would like to focus on capacities. And each person has a local capacity and an inherent capability for resilience. However, to ensure that local communities are respected, their voice is heard, systems capacities are also varied. So if you really want the workers to be protected, the ecosystem in which they operate, which is a systems capacity which remains varied in different states, also needs to be worked on. So for example, I may make a woman empowered in her own house, but if people around her are not or don't feel, she'll be back to square where she is, right? So similarly, what we have seen is that while women are moving forward, is the system also responding in a similar way? One, in terms of reaching out to them, I think COVID pandemic has taught us how to actually come up with swift, simple, non-fancy, near perfect communication methods that reach them quickly. If you look at any of these 3 points, and from my experience that I'm saying, if you want to have more gender responsive processes or more recognition or more capabilities, it could be possible that the same process is followed of task force and another module and another cascade. But that's not working. We don't need that. Workers don't need that. They need a support system and an accountability system that makes people that if you do this, it's a punishable offense. You have to recognize. We have to bring them to the forefront and support them in their work. They have the capacity. At the end of the day, the COVID pandemic has taught us that we can't do without those that are actually in the margins. The people who you needed the most were the ones you neglected the most in your lives. So they have the capacities, and that's why they are the only ones that are risking their lives doing active surveillance. We are locked in our homes or in our offices. They have the resilience. Does the system have the resilience to protect them? And what is the system doing? And their accountability comes. So if the trainings are not happening, if the people are not getting incentives, if the people are not getting the smartphones, who is holding the mid-level or the senior level cadre accountable? And hence, once there is a supportive policy environment, there is money that is being down, but is the money trickling to them at times when they need it most, and providing them a supportive system? And hence, my request here is that frontline workers' remuneration, service cost should be added to the work that they are doing. It cannot be a volunteerism issue at this point in time. And I say this particularly in the context of the National Rural Livelihood Mission, where if the women self-help groups who are only doing savings and credit are also now providing take-home ration, are they being provided an appropriate cost indexed service cost to their work? Because otherwise it's a very failed business model. So let's look at it in that perspective. It's always science, society, and statesmanship that brings everything together. You need all three. Just statesmanship will not work, just the society will not work, and just the science will not work. So I think the science and the statesmanship has come through policies and having the right people. The society needs to be brought on board. Thank you.
Thank you, Dr. Sethi. That was very insightful. Thanks for bringing in a systems perspective of working on the various dimensions and the aspects, and also bringing in the important point about building the capacities of the system and not just focusing on the health workers. Over to you, Dr. Hilde. Your thoughts.
They need to team up. They need to team up for creating greater understanding of how gender dimensions affect women in the health sector. And we should use every opportunity to take some corrective action, no matter how small it is, not once, but again and again and again. Then on the second point, for ASHAs and the other frontline workers, we need to ensure that social protection measures are in place. Systems need to be set up, that their healthcare needs are taken care of. And on the capacity building, well, capacity building should be part of any project, any kind of activity. It should be planned early on in the startup of the activities, and it should always be done with input from those who will be the beneficiaries of the capacity building. People are not ground zero. They should have a say in how training programs, capacity building initiatives are shaped. Thank you.
Thank you, Dr. Hilde, and bringing in the idea of including the voices of those for whom the policies have been made. Dr. Nanda, what would you suggest at this point moving forward?
I think I covered a lot of these points in what I said, but then maybe I will emphasize just based on what's been said. I think the foundation is that you have to be remunerated respectfully for your labor, and you have to get timely payments. So even now, there's a lot of reports from the field that the top-up package of 1,000 rupees a month, it's firstly only for the 3 months. I don't know, Rajni will tell us if it's been extended, but the 3 months are almost over. And many health workers haven't actually got that. And that is really the story of their lives, is not to be compensated on time equally for what they're putting in. And this whole other aspect of unpaid time and unpaid labor. So I think that's a really serious issue. if we want to professionalize this cadre and we expect professional quality standards, then minimally we need to have some protection financial. And it's not just a protection because of a pandemic, but it's the protection of what you rightfully put in. So I think that's a really important starting point. And I think that kind of recognition of their status is really important to lift their status within the health systems and in their community, that they're recognized as professional members of the health system and very important social brokers of the health system to the community. I think a lot of changes could happen with just that kind of recognition. I do think that male health workers, whether they're sanitation workers or in other sectors, may get transportation. They may get different kinds of privileges which female health workers don't get. So we have to really look at it pretty seriously as to how do we have not only wage parity, but parity in other kinds of incentives and privileges. And my third thing was that I think about progressive, I'm not going to call it gender transformative, but progressive, a system that can accommodate as well as all the essential services that are also growing including, AIDS. We have and invest in education for public health in rural settings, and I would say prioritizing gender and STEM. So really emphasizing education for women and young girls in STEM would become a really important way. I'm thinking 10 years from now. We can't keep fixing band-aids in the system as it is. We also have to design a system that we want. So that's it from me.
Thank you, Dr. Nanda.
Can I just say one more thing, please?
Sure.
Okay, so I also want to say that, we're doing a lot of research also. Again, I keep going back to Rajni because I know this whole compendium is going to come out on the use of digital technology for building capacity, improving performance, and improving outcomes. I want to say that digital is a really important platform, but that is not a complete solution. It's a platform. We have to again situate it back in the context, and I think a lot of people already talked about the disadvantages. So I think that it is an opportunity. We should really think of it as an opportunity. But people talked about enablement of smartphones, access, equalizing those differences. I would say if digital is the way we're going to go, then really let's start with minimally enabling equal access to digital technology.
Thank you. You brought in very important points for remuneration, protection, parity, investment in education for STEMs, and also highlighting how digital component is just a platform and cannot be a solution. I'll quickly move to Ms. Prasad for her reflections, and then we'll take on the questions from the audience. I also would want to tell the audience to please keep posting their questions for the panel.
Yeah, I think I made some of the points in the opening remarks, but I would reiterate some of those. I think in terms of just thinking of different cadres very specifically, not just as individual cadres delivering different sets of services, but where they really fit into the overall bigger picture and organizing them accordingly. I think that is something which we still need to do a lot, although a lot of programs have made progress on this. But I think we do need to take that forward. And looking at data, again, very strategically, what data we're collecting for whom, for what purpose, and making sure it feeds back to the people who are actually collecting this data and makes sense to them. I think this is something Dr. Hilde touched upon as well. So I think those are two pieces which I would reiterate from what I said at the beginning. The third one, I think, especially at the national level, because I think the further away you're from the ground, in a sense, it's almost harder to, constantly hear voices from the ground. So I think this needs to be institutionalized, and there needs to be a mechanism, perhaps a forum in place, where we can get perspectives directly from these different cadres, not just in health, nutrition, but education. We heard about education as well on the panel. So I think sort of have a safe space where different cadres, their representatives can actually feel comfortable sharing their challenges, sharing their perspectives without any sort of fear of consequences, and also having some of the civil society people represented in these, because I think being at Niti Aayog, we do interact a lot with civil society. We're also working on the aspirational districts program, and we've really seen the benefits of hearing directly from people on the ground. In terms of civil society, we know that a lot of them use the community-based health workers in a very, very strong way in tuberculosis, for instance, in contact tracing, and they have very thoughtfully, conceptualized all their monitoring, their incentive structures, etc. So I think there's a lot to learn for us at the national policy level. And I think while we do, get a lot of feedback from states, I think it would be good to also have an institutional structure of forum which can allow us to directly hear these voices from the ground and continually sort of reform our policy making accordingly.
Thank you, Dr. Prasad. I think this is a really interesting suggestion in terms of institutionalizing the mechanisms for hearing the voices from the ground, and also having a bigger role for society last of the panel list, and then go on to the questions.
Well,
Yes.
And if we want to support and further strengthen the frontline health workers, it can't be just one intervention. You really need to look at all the different aspects, and that's where the challenge is. Make it cohesive and be consistent and address all the different elements.
I agree with Hilde, and I think, sorry, can I go on?
Yeah, please.
Yeah, okay. So, I agree with Hilde. It's a multiplicity of interrelated components, but I also think we have to have a sort of a roadmap and a vision for a decade. For 15 years, we've seen the program evolve, and we've seen it evolve in fits and starts, I would say. So I think, and I know that roadmaps, can be bumpy and things don't go as you plan, but I think having a roadmap for the future, given that we have now enough data to say where we are headed, let's say at least until 2030, having a roadmap for frontline workers, their contribution to primary health care, to public health, I think would be a very useful contribution, taking all of these components, and we know enough now. Plus, we have a lot of ideas coming from different parts of the country, from different parts of the world. How do you link them to the kind of structures that Vani spoke about? How do you link them to local self-government organizations, which we didn't hear much about, despite the fact that women constitute 1/3 of those groups? I think that kind of a roadmap is really important. Thank you.
Thank you, Dr. Ved.
Can I?
Sethi, were you saying? Yes, please.
Yeah. So I think putting an equity lens to the systems approach that India uses, because that will help see how we can adapt our supplies, our financing, our HR support, our partnerships, our communication and community engagement in those areas. And I say this with respect specifically because it is the most marginalized, and those are the margins that have been affected very undignifiably in this pandemic. The migrant workers, the people in formal sector, and that's really unmasked the system's capacity to provide equitable access to public goods and services, specifically to the poorest, who have been on the last edge. So our peri-urban areas, our urban areas, it's really time we focus on them, because it was the pre-COVID system's capacity and the pre-COVID partnerships that the state governments had that determined how resilient they were to actually respond to the pandemic. So responding to the pandemics like this is the 20th pandemic, this is the 20th actually emergency in 2020 actually. It's not the first. And these are going to continue. So the role of the people at the front line is changing. At the same time, India, in terms of nutrition, is faced with actually a double or a triple burden of malnutrition. And even the problems there are changing. And with the pandemic, they're going to change even more because of the rising food prices. People are going to go back there. There is space to listen, there is space to contribute, and finally harmonizing also between the partners. We talk a lot of convergence between governments and between governments. What about development partners themselves, and how we can come together as a collective of one voice, one response, and one support to the government? So it's practice what you preach, take care of the poorest, and do things what you would do for yourself, do that for others. Thank you very much.
Thank you, Dr. Sethi. That just takes us to a more clearer path, and not just us, but all the panelists here representing various different development partners. Thanks for bringing in the idea of equity and how that can be a cross-cutting principle that we can take into account while forming these policies. Moving quickly to the questions from the audience. One of the attendees have been asking about the mental health services. And the question says, is there an assistance for mental health services for frontline health workers? What about in cases where the numbers are bad? And I would open it to all panelists, whoever would like to respond. Dr. Sethi, you're not audible, you're on mute.
I think Rajni ma'am would definitely be at the forefront knowing this and about the support NIMHAMS is providing across the country. However, how they are layered and working together with the Ministry of Health within the COVID response. So there's a separate mental health guidance which is being sent, but and Ministry of Health has their own guidance that is being sent. So I would really wish that a time comes when mental health, psychosocial support, and anxiety management during COVID is a part of, the government one guideline that's sent out. But I am aware that in several states, SHRCs and NIMHAMS state teams are working together to provide helpline numbers. They've come up with the 4-charter strategy to support women also. How far it is gone, it is it's not going at scale, but I think this pandemic has taught us the importance of working on anxiety, mental health. And while it was done through some NGOs or randomized control trials, some community-based support systems, there is a mental health department in the Ministry of Health also. I think it's time that, they are recognized for their role, and also they play a more proactive role in such pandemics. Thanks.
Thanks, Dr. Sethi. The next question is, yes, please.
Can I just add to that? Yeah, I mean, I think she's covered fairly comprehensively the fact that there are several guidelines. There have been, it's part of the essential services document that the ministry released. But I think in these times, more than guidelines that come from the center and the state, it's the collective solidarity that's built between ASHAs, between the support structures, between the ASHA, the ANM, the Anganwadi worker, and between other collectives in the community. And I think that's important. Of course, we have to provide them with the support that they need, but this collective solidarity building needs to be a conscious part of our strategies as we go forward. Heaven forbid we will have another pandemic, but this we learn that these solidarity systems and platforms are very important. Of course, you can layer them with professional psychosocial support, anxiety counseling, but I think that we have to recognize and build upon those platforms that exist in the community.
I agree.
That's a really interesting point for us to reflect on. And we haven't really been thinking around those areas, and the whole idea of mental health has been so biomedical and technological, and ideas that we really fail to take into account the community perspectives and the solidarities that we should be looking at. Moving on to the next question, says, do ASHA workers in different states have unified roles? For example, does an ASHA worker in Tamil Nadu have the same set of responsibilities as the ASHA worker in Kerala? And who's responsible for designating them? Open to you all.
Take that one, please. So, there are not unified roles, but there are these unified functions. That the ASHA is a link worker, that the ASHA is a provider of community level care, and that the ASHA functions as an activist and a community mobilizer. In Sikkim, she may do more work related to chronic diseases. In Kerala, she's certainly doing more work for chronic diseases, whereas in UP, MP, Bihar, she needs to do much more RCH work. So her role, the tasks that she does are defined by the population that she works with. And it's up to the states to decide what roles their ASHAs take on. Of course, they're guided by the national level, but they're also guided by the needs of the state. So there's a mix of both there.
Thank you, Dr. Ved. Would anyone want to add on to that and reflect more? Shall we? Next question is particularly, I believe Dr. Ved is best positioned to answer it again. And but I would love to hear reflections from everyone, and it's going to open a Pandora box for all of us sitting here. And the question reads like, what are the reasons for policy not translated as intended at the field level?
That's a question just for me. I think everybody here on this panel is very well qualified. So why don't other people take a shot at this, and then I'll answer last of all. गायब हो गए क्या हम?
Looks like. Dr. Nanda, would you want to start with that?
I do think that you can't tweak the system right at the bottom. So even if the policies are addressing remuneration or roles or competencies or respect and dignity for ASHAs or frontline workers, the push for any of this to be executed comes from many layers above the system. So I do think, I'm repeating the same point, supportive supervision, more progressive, responsive, sensitive leadership to really understand the issues that we are talking about around frontline workers and to be sensitive to that. It's going to be really important for all of this to be executed. So even with the best policies, I think it has to go through an entire vertical or hierarchical health system. And the interest of the health system or the actors within the health system are not necessarily geared to, improve the status of the frontline worker. In fact, her status is the least of the concerns. And also sometimes the interests are geared away from that, and even the health worker will become part of that very kind of perverse effects. And I don't want to go into details there, but basically, I think you have to kind of create the incentive for change at every level. And it has to come from, and it has to be connected. And to the point that Rajni was making earlier about Asha being part of that connected tissue of the community, understanding that whole continuum is really important. And any one policy that is trying to change something along the continuum will have effects along other aspects. So really connecting her differently with community, with local governance, with panchayats, with other kind of community groups, as well as with facility and system level actors. And for people to understand why that policy is important. Actually, what happens for women workers is often when you even design the most progressive policies, the backlash comes from other actors in the system, which would be that which would be trying to kind of really undermine that very change that you're trying to cause. And this is not just about ASHAs or health system, it happens all the time. So you have to make other people who are the key influencers and ambassadors of those policies understand why those policies are important.
Thank you, Dr. Nanda. Would anyone else want to add on to that? There's an additional question which is linked to it, to say how long does it take to come actual plan of action on real ground?
That will be based on the system's capacity. So once the guideline is done, and if the guideline is simple, clear, 1 or 2 pages, very clear on what they have to do, what are the budgets available and their unit costs, things are easy. The longer the guidelines, more confusing, the less able leadership at the lowest level, more confusing, and will take more time. So governance and leadership play a very, very important role in translation of any policy down. Workers manage, they will work together somehow.
Thank you, Dr. Sethi.
which
Dr. Ved, would you?
To which I would add, consultative and participatory processes in defining policies and having them translate to programmatic, they catalyze that process. So if the policy has been developed where there's ownership of many of the stakeholders, not all, my experience is that it just gets translated faster. How you can put a timeline to it, I cannot tell. Some things take off very quickly and some things take a long time. But I think participation is important.
Thank you all. There's another question too. Why does the peer workers who were the frontline workers in controlling the HIV pandemic were given due recognition in case of COVID-19? Would you please state your question again? Or if you would want to speak, we can put you on the speaker as well. Why does the peer worker who were the frontline workers in controlling the HIV pandemic were given due recognition in the case of COVID-19? Were not given, sorry, were not given. We've got a correction to say were not given due recognition in the case of COVID-19.
I think maybe I'll just, make a sort of point here in general on this. I think this is an issue for us really across in terms of, really, I think it's, recognition, but also just learning from, our different areas. And I think this is a problem we face in health, particularly. I think even, when we look at our data systems, each of our programs has had their own data systems. And of course, we're not trying to address all of this through integrating it. But I think this sort of applies to all different aspects, even in terms of learnings. I think whether it's HIV, whether it's TB, there's a lot that we've learned already in these areas, which can be applied to COVID-19, which can be applied to various other situations as well. So I think in general, I do think that we do need to get sort of better in terms of how do we acknowledge our experiences, leverage them across, and also I think utilize our workforce more, suitably accordingly, because I think there's a lot of people out there, who would have dealt with HIV, who would have dealt with various. I think even when it comes to the stigma aspect of COVID, this is something that I've tried to raise a lot. That in many other diseases as well, there are various health workers, various health professionals
I think we just lost connection with Ms. Prasad.
health.
I think we just, in the interest of time, would like to conclude today's session. Thank you all for these wonderful suggestions, joining the panel and enriching the discussion with your own expertise and your experiences in the field, and especially for working for the front lines. Sorry, Ms. Prasad, you were saying and then you got cut. Do we have a stable connection? Thank you all participants for bringing in these extremely relevant and important questions, and not just today, but also for the previous ones. In the interest of time, we'll just conclude today's session. And we believe that in this week, we started with this idea of amplifying the contributions and challenges of female frontline health workers. But we've seen that in this 1 week, we've moved from mere amplification of the contributions and concerns to coming up with suggestions from you all and from the participants, moving towards a more concrete, actionable points, and we'll take that on. Thank you all who've reached us via social media, via emails, sending us our suggestions, more ideas for moving forward from here. We'll compile all these suggestions and share our feedback for the next steps. We'll, taking on the point from all the panelists on not taking all the female health workers and clubbing them together. We've tried to intentionally divide sessions plans for frontline health workers. In the next webinar, we'll look at the issues of ANMs and nurses, and we'll hold a different series for one for ANMs and one for nurses. And hopefully by the end of June, or maybe in the first week of July sometime. Also, we'll share a feedback form with you all. This was our first event, and we would appreciate any kind of feedback that you have for us to improve and also partner better with like-minded people to take the movement forward. Lastly, I would like to thank the WGH India team, the Chitkara team, for putting this together, for what I would want to call making it a success of getting you all on this panel, hearing from you, and also hearing from the community stakeholders, the ASHAs themselves, their trade unions, members, and also from various state representatives. We were very fortunate to have northeastern states being on the panel, and also people from the Jharkhand joining us, and ground level NGOs, which we feel do not get to say much in terms of mainstream discussions like these. A special thanks to the Secretariat at Chitkara, and we look forward to more collaborative work together. Thank you all for joining us.